basic principles in laparoscopy. I am Adrian Gomez, current fellow in training in this institution for advanced minimally invasive surgery. Okay, so these are my objectives for today's discussion. Okay, so if you search for laparoscopic surgery in Google, Gemini will tell you this. Laparoscopic surgery is a minimally invasive procedure where a surgeon uses a long, thin tube with a camera inserted through small incisions to view and operate. So why do we do laparoscopic surgery? We all want better outcomes for our patients compared to traditional open surgery. All these advantages stem from the smaller incisions created. Currently, the scope of laparoscopy evolved from diagnostic laparoscopy to more advanced and complex surgeries. So these are the basic components of the image system. So minimally invasive surgery is a technology-dependent specialty, and every surgeon is expected to have a good background knowledge of new instruments and imaging systems. So the image system is an integrated chain from the telescope to the monitor with the goal of this: consolidating bright illumination, high resolution and color with minimal latency to maximize patient safety, efficiency of surgery, and minimizing surgeon fatigue. Okay. So the telescopes in laparoscopy can be rod, lens scopes, or the newer digital chip-on-tip scopes with diameters ranging from 10 millimeters, which provide the best brightness and clarity, to 5 and 3 millimeter needle scopes, mainly used in pediatric cases. So they come in 0 degrees straight viewing, best used in abdominal access, especially using optical trocars. You also have angled scopes to allow better off-axis visualization. Again, bright illumination is one of our goals to provide safe surgery. It is critical for safe dissection and orientation. We have two most commonly used in this current age of laparoscopy: xenon and lead. Previously used light sources include quartz halogen, incandescent bulbs, and metal halide vapor arc lamps. Most light sources nowadays use high intensity xenon, which provides bright white light. Although newer light sources incorporate the use of LED technology due to their energy efficiency, lower heat output, and longer lifespan, thus reducing the need for lamp change. Cable quality equates to good light delivery. There are two types of cables: fiber optic and liquid crystal gel. Both of them transmit light from source to scope. They differ significantly in construction and performance. Fiber optic cables are flexible, do not transmit precise light spectrum, have high quality of optical transmission but are fragile. In contrast to liquid crystal gel, which are rigid, they transmit the complete spectrum with more light, but more fragile and cannot be gas sterilized. Currently, there are two new systems in video technology, namely the UHD 4K system and the 3D system. The traditional camera contains either a solid-state silicon chip or the charge-coupled device. A standard endolaparoscope contains approximately 250,000 to 380,000 pixels. The resolution and clarity of the image depends on the number of pixels on the chip, and interestingly, will also depend on the resolution capability of the monitor. So it has to be compatible. The 3D system was developed to overcome the lack of depth perception in the traditional 2D laparoscopy. In 3D laparoscopy, different images are presented to each of the surgeon's eyes to facilitate stereopsis. This is accomplished using two different technologies: the single-channel laparoscope, which uses one system of lenses for both eyes, then using a digital filter to separate the images for each eye, and the dual-channel laparoscope, which uses one lens system for each eye. In both technologies, it is necessary for the surgeon and the nurses to wear stereoscopic glasses. So this is a schematic diagram of what is going on with the three-dimensional system. The camera captures two different images, the left and right, and then the 3D controller unit processes the image captured and is delivered to the 3D monitor. Using the 3D glasses, surgeons and nurses will be able to perceive the image as 3D. The disadvantages to the 3D laparoscopy include higher cost, the need to wear 3D glasses, and eye fatigue. Main advantage over the 2D system is better depth perception. So the controller unit works like a CPU. It processes video signals from the camera head to the video monitor to provide accurate visualization of the operative field, converts video data to high or standard definition. Other controller units combine both image processor and light source functions. The monitor. There are different kinds of monitors available in the market for as long as it is medical grade. We have LCD, LED, and the newer OLED monitors. As a general rule, monitor resolution should match the camera output. Use of video cards, as shown in the photo, allows greater flexibility, and maneuverability allows ease in positioning, especially in advanced cases. This is the Endo Alpha suite we have in this institution. This is an example of an integrated operating room. Integrated ORs link the video, audio, patient data, and lights via a central console. Ceiling arms are used instead of carts to allow ease in positioning. Integration reduces door traffic, enables education and teleconferencing. Generally, it boosts efficiency and safety by centralizing control and routing. The next part is ergonomics. So, ergonomics can be defined as the scientific study of people at work in terms of equipment, safety, productivity, and training. In other words, it is the science of best suiting the worker to his workplace. The main goals of improving ergonomics is in laparoscopic surgery are to reduce the physical strain and fatigue, prevent musculoskeletal injuries, enhance the surgeon comfort and well-being, and ultimately improve overall surgical efficiency, safety, and patient outcomes. So the straight line principle in laparoscope involves arranging the surgeon, the instruments, and operative target and video monitor in a straight line. This actually depends on the organ target. This coaxial alignment minimizes fatigue and strain for the surgeon by optimizing the visual and motor axis. So as you can see in these images, these are some examples of procedures wherein you have to arrange the surgeon, target organ, and the monitor in a straight line. Triangulation is the principle of placing trocars in a triangular arrangement relative to the target organ. This positioning is a cornerstone of surgical ergonomics. Target organ should be approximately 15 centimeters from the camera port and working instruments approximately 5 to 7 cm apart. The baseball diamond concept is a common analogy used to describe triangulation. Working angles. These are the working angles that we need to know during laparoscopy. The manipulation angle is the angle formed between two working instruments. It is ideally at about 45 to 60 degrees. The azimuth angle is the angle between the instrument and the optical axis of the laparoscope, ideally kept at 30 to 45 degrees. And the elevation angle is the angle between the instrument and the horizontal plane, which should match the manipulation angle, ideally around 60 degrees. All these angles, instruments move freely without clashing and allows precise tissue handling. This ensures that instruments are always working within the visual field and along predictable trajectories. So the ideal posture for the surgeon during laparoscopy is a relaxed stance with elbows flexed at 90 to 120 degrees and shoulders slightly abducted. The table height should be adjusted so that the instruments rest below the elbow level. Monitors should be positioned directly in front of the surgeon at 90 to 200 centimeters distance and is set about 15 degrees below the eye level for a gaze down view. These adjustments altogether reduce fatigue, improve precision, and protect the surgeon from long-term musculoskeletal injuries. In summary, success in laparoscopy relies on the basic components and image systems, which is the scope, the camera, the light source, and the monitor. Safe exposure and orientation are core principles. Always operate under direct visualization. Ergonomics setup, surgeon posture, table height, monitor alignment, and working angles. They enhance the precision and it prevents fatigue and injury. And combining technology, technique, and ergonomics ensures safety, efficiency, and better outcomes. Thank you.
Thank you so much, Dr. Gomez, for the introduction and basic principles. Next, to deliver his own lecture on laparoscopic equipment and OT setup, we welcome a renowned general surgeon and honorary lecturer all the way from Malaysia. He is a life member of the Academy of Medicine Malaysia, SELSMA, and the Malaysia Hernia Society. He is a skilled in minimally invasive surgery, general and emergency surgical procedures, endoscopy, dialysis and vascular access, and advanced wound care. He has received multiple outstanding service rewards and awards and extensive training in laparoscopic, hernia, bariatric, endoscopic, and trauma surgery, including international workshops in Taiwan, Singapore, and Thailand. As an active trainer and speaker, he has led numerous surgical workshops across Malaysia and abroad. He has contributed to research and publications such as Open Access Surgery in BJU International. Let us all welcome Dr. Hao Piao Lo.
Hello, good morning, everyone. I'm Dr. Loh from Malaysia. All right, I work in Hospital Ipoh, one of the, still in the government service. Right. First of all, I would like to thank Prof. Lomanto and also Dr. Henry for inviting me all the way from Malaysia to Philippines to help out for this workshop. Thank you, Olympus, as well. All right. So today I'm going to give the first lecture regarding laparoscopic equipment and OT setup. So this is my hospital, all right? This is a Hospital Ipoh in it's a state hospital, right? Next, disclosure: all images and the reference to the instrument brands presented in this lecture are educational purposes and carry no advertising and promotional intent. So as the lectures go along, you might realize that some of the lectures might be a bit overlap with the first lecture, but it's just going to be a run through. So what is the outline of my presentation today? Basically, we're going to talk about OT setup for basic laparoscopy surgery. And then we are going to talk about what is in the laparoscopy tower, which is a monitor, display, camera head, telescope, light source, and insufflator. And then other associated equipment as well, and also the common laparoscopic instrument. First, what is the OT for laparoscopic surgery? This is how the OT setup in my hospital. So this is how it's roughly going to be. So let us go through one by one what is in this image. First, this is a laparoscopy tower rack, followed by this is a monitor. This is actually the insufflator. This is the processor module. Down here, this one is a light source. Over here, this is a diathermy machine. This is a smoke evacuator machine. And over here, these are all the laparoscopic instrument. On top here, this is a laparoscopic and also the fiber optics light cable. And lastly, we don't forget, we need to have the OT table to position the patient. So this is roughly the whole how the OT setup going to be. So in my lecture here, these are all the laparoscopic equipment that I'm going to talk about, which is include the monitor, the processor module, the camera head, the laparoscope, the telescope, and then the light source, also the fiber optic light cable, the insufflator machine. Next is the CO2 tank, followed by the smoke evacuator machine, followed by the diathermy machine, and lastly, for all the common laparoscopic instrument. So all the image I'm going to show you is all in the first picture in the OT. All right, so we just quickly glance through. So this is actually the processor module together connected with this laparoscopic camera head. And what is in this thing showed, this is a fiber optic lights and on a button, followed by this is a white balance, is to reset and zero the white color according to the surroundings. You do the white balance before you put in the telescope inside to examine the patient. Followed by the brightness is to adjust the lighting of the laparoscopy, and it can be manual or auto. Followed by this digital zoom, where there's a software-based enlarged portion of the image by cropping, but occasionally they will reduce the image quality. Lastly, there are multiple functions depends on the processor, which include the yellow enhancement or the infrared or other settings such as the narrowband imaging, 3D or ICG. Then there is the connector head to the laparoscopic head. Next, this is a laparoscopy monitor. It can be HD, LED, OLED, or even 3D. Next, laparoscopic camera head. This is slightly older version of the laparoscopic camera head, and this is what we call the ocular coupler. This is a ring dialer for focusing. This one is an optical zoom, also is a dialer. And then this is called the video sensor housing, which last time there are 3 chip. It is start from a 3 chip sensor, which is from the green, red, and blue. Lastly, these are the program functional selection. But now there's a newer camera head where this is also called the ocular coupler. These are all the buttons to control the manual focus. Followed by this is one is autofocus. While these are all the programmable button functions for digital zoom. Next, telescope. This is a normal telescope. Every time when we do the laparoscopy surgery. So what are the components? This is the outer tubing. This is the body, and this is the light post, and lastly this is the eyepiece. Last time this is how it's made. It's made by the conventional glass lens telescope, where these are all the conventional glass lens in between the telescope. However, now whatever we use now is actually using the Hopkins rod lens telescope. What does it mean? Despite of using the small lens, they're using the rod lens, which is a bigger and wider one. However, these are the spaces. So why use this Hopkins rod lens? When you use this kind of lens, this is how it looks like. It's quite clear. And then this is basically the main thing why we are using the Hopkins rod lens, because number one, the long glass rod lens will give a much brighter, sharper, wider, slimmer image, and is more durable. And nowadays, all the telescope is using this Hopkins rod lens. This is the common telescope that we all use. the 5 mm and also the 10 mm. So the first one is actually the 5 mm 30 degree. Second one is a 5 mm 0 degree. Third one is a 10 mm 30 degree. And the last one is a 10 mm 0 degree. So note that the 30 degree, it will be slightly slanted over the head, while the 0 degree, it will be a straight one. So when you put the camera, the 0 degree and the 30 degree, this is how it's going to look like. The 0 degree, it straightforward, we will see at the front, where the 30 degree, it will be slanted downwards, where you don't see the in front view, but you see slightly lower down view. So in 30 degree, when you put your light source head straight up, it will going to see straight down 30 degree. And when you put it slanted to the right side, you will see over to the left side 30 degree. Whereas if you put it over to the left side, you will view over a 30 degree towards the right side. In other words, means that by using a 30 degree, you can actually have a better and more view towards the left and the right side for a better dissection surgery during the telescope. Next is a laparoscopic light source. This is how it looks like. So it consists of a light bulb, heat filter, condensing lens, and also manual and automatic intensity control. So in the lighting, it's a white light illumination, and the bulb last time is a xenon, mercury, halogen, and nowadays they are using LEDs. Next is a laparoscopic fiber optic light cable. This is how it looks like, okay? The laparoscopic fiber optic light cable. And inside is all made by fiber optics. And when you connect it, when you lit it up, this is how it looks like. Next is a laparoscopy insufflator machine. So there are multiple functions, but basically there are four main things that I need to bring up to you here. Number one, the pressure. This is the pressure control. Usually we set around 10 to 12 millimeter mercury for the pressure control to do our laparoscopy surgery. Next is the flow. It's how much air we want to get the air in during the surgery. We usually start with a low flow. When we start the surgery, basically is to avoid gas embolism and also to avoid the barotrauma. However, in our usual usage of surgery, we will usually use a medium flow, which is around 3 to 10 liter per minute. However, when you're doing suction or you want to irrigate, then you probably would want to increase until high flow, which is around 10 liter per minute. Next, the volume. This just shows that what is the total volume is being used, CO2 is being used during the whole surgery, from the surgery start until the surgery ends. For this thing, there's one more thing, which is the first small thing there, which is the CO2 tank indicator. It will show you that how much CO2 is left inside the tank. And this is very important because halfway of the surgery, let's say the tank is going to finish, you need to ask your assistants to help and prepare the tank rather than halfway the surgery, you are interrupted. Lastly, some of the machine like this one, there is a smoke evacuation device there. Next thing, we don't forget, beside the laparoscopy tower, usually behind there, there's something called this CO2 tank. CO2 is being used as an insufficient gas because number one, is colorless. Number two, is non-flammable. Number three, is highly soluble to blood compared to air. And lastly, it's easy to absorb by blood and wash out from the body via ventilation. Next is a laparoscopy smoke evacuator, where you evacuate all the smoke whenever the laparoscopy is being done. Followed by next one, the diathermy machine. The diathermy machine, by standard, there will be monopolar and bipolar function in this machine. Next is the laparoscopic instrument. So what are the laparoscopic instrument? Laparoscopic instrument means that the instrument used to substitute for general surgery equipment for laparoscopic surgery. So what are the components inside this instrument? This is actually the tip. This is actually the insulated outer tube. This is called the rotator. This is called the handle. And lastly, this is an attachment for electrosurgical cords. Some of the handle are actually ratcheted so that you can hold the thing without keep on clenching on the handle. Next, how do we actually classify the laparoscopic instrument? There is a reusable one, which is actually can be autoclave or chemical sterilization, and they are assembled parts. So you can see here in the diagram, the instrument, the laparoscopy equipment is actually can be disassembled for you to do the sterilization. However, there are single-use one, which is you use and discard. And usually this is a one-piece instrument that you cannot actually disassemble it. So next is I'm going to show you what are the common laparoscopic instruments. First one, Johann forceps. These are all the atraumatic grasper for the bowel. Johann forceps, single action Johann forceps. Johann forceps, the first one is both jaw can be open and closed, while the second one is only one side can be open. Second one, this is a Babcock. Next one, this is a Debicki forceps. Next, this is a Crocker omni forceps, which actually is a bowel forceps, but then over the tip there is slightly slanted for a better grasping for the surgery, especially for hernia surgeries. Lastly is a long Johann forceps. Next, these are all the grasping forceps, which the first one is called clinching forceps. Second one, atraumatic forceps. Next one, this is the Metis forceps, which is actually looks like our usual Alice forceps that you use in your open surgery. Next one, this one is called the crocodile forceps. These are all the dissection forceps, which the first one is Maryland forceps. Second one, the straight Maryland forceps. Next one is a 90-degree forceps. Usually we use it during our lab colis. And last one is a precision forceps. Next, we need to have scissors as well. The first one is called the maximum scissors. Second one, straight scissors. This is the bipolar instrument, and this is called the needle holder. Some of the needle holder is just a straight needle holder, while some are actually self-aligned, meaning that when you put your needle and hold it, it will automatically hold it in a proper position for you. Next is a suction and irrigation, where that is called a trigger, and the other one is called a suction tip. Next is a laparoscopic hook. There is a J hook tip, L hook tip, and also the spoon tip. Next, these are all the retractors. First one is a Nathanson retractor. Next one is a fan retractor. These are laparoscopic clip applicators. And this is a retrieval pouch. And lastly, this is a suture passer. So in conclusion, we have to understand and familiar with all the basics laparoscopic equipment, and so that we can able to handle laparoscopy equipment properly to ensure a smooth and successful surgery, and to ensure a safe surgery, and able to troubleshoot the equipment error efficiently, and also to maintain longer lifespan of the laparoscopy equipment. That's all. Thank you.
Thank you so much, Dr. Lo. And up next, we have a continuing lecture with the topic on access and complications. Once again, Dr. Hao Piao Lo.
Hi, good morning. It's me again. So next we're going to talk about laparoscopic access and complications. So same disclosure. What is the outline? Number one, we're going to talk about laparoscopic access, about the ports, about the methods, about the comparisons of the methods, and also the principles of access. Next, we are going to talk about complications of laparoscopic access from the short-term, long-term, complications of pneumoperitoneum, and also how to prevent it. So first of all, let's just go to the port access device. This is called a Varus needle. And then when you want to check it, you need to make sure that it is loose and you are able to flip it, all right, freely. You cannot force it. And then this is how you hold a varus needle, like you're holding a pen. And then lastly, this is where you're going to put it. First is by putting over either the umbilicus, the incision that you made, or this is actually, you put it at the palmar's point, where it is 2 centimeter at below the costal rib at the mid-clavicular line. Next, this is a disposable single-use plastic pot, or we call it the optical pot. You can disassemble this pot, and these are the upper one is a cannula, which the left side shows the cannula sleeve and also the cannula handle, and the below part is actually the trocar. It is called the tip, trocar shaft, and also the trocar handle. Next, this is how it looks like. Next, this is the Hassan trocar. It made from 2 components. The tip is actually blunt. And this is a metal trocar, which is actually reusable. Next, just a short run through regarding principle of access. So first of all, very important, triangulation. Number 2, we talk about the angle. So azimuth angle is actually the horizontal angle between the camera and one working instrument. And this is manipulation angle, which is an angle formed between 2 working instruments. So how do you actually estimate the distance between the pods? So we can use the rules of hand, okay? Very simple one, which is, let's say you're going to put the camera pod at the umbilicus, and then the X shows the part where the target surgery that you're going to do. So you put in the laparoscopic pod, then followed by this angle, estimate the angle. Then followed by you use your second hand to put in the second part, third part, then this is how it's going to look like. All right. So laparoscopic access, first of all, let us go through the closed method. So in closed method, you open up the umbilicus. Then after that, you can use a towel clip, and then just grabs it up and then just push in a needle. There will be only one click go inside, and then you can start connecting to your gas tubing and inflate the abdomen. However, there's another way of doing it where you actually cut the umbilicus just below do a infra-umbilicus incision and hold the varus needle like a pen, hold your abdomen up, and then you just put in the varus needle. You can inflate water and make sure that it's freely flowing in and out. Or the other way you do it is by doing the water dropping method, where you drop a water and then you lift up the abdomen and you see the water will actually go in. Next, you will connect to the gas tubing and wait the abdomen to be distended. Usually, you start out with the low flow, like what I mentioned just now. Then after that, once it's distended good enough, then you take it out. And then you just use your pot and just shove it in. This is called a closed method insertion. Next, we go to the open method. So in open method, you can use your your blade or your diatomy to open up a infra-umbilical or supra-umbilical incision. Then after that, you use a retractor, retract your fat, and then you start to dissect around it until you see the linear alba. Once you see the linear alba, then you will use a blade or scissors to cut through it. Then, because it's at the midline, everything is condensed together. So once you open that up, it usually will reach all the way down to the parietal peritoneum. Next, open up the parietal peritoneum. And you can either use a forceps, or you can use your fingers to open up and swipe below it to make sure that you actually go into the peritoneal cavity. You put in the Hassan stroker, and then you inflate the balloon inside. And then you can remove it out. And that's it. You have put in the trocar, camera trocar, the first trocar, by using a open method. Next is the optical trocar method. This is the optical trocar, all right? So that is the place where you put in your telescope, and then that is the tip, and then when you put it in, then you will need to screw it inside, right? So we'll show you in the video in a short while, all right? So again, you make an incision, followed by straight. You can see you put in the telescope together with the optical trocar, and then you just park just above it, just nice. Then the next thing, you look at the video. You go to the subcutaneous fat, the anterior rectus sheath, posterior rectus sheath. Then you will go through the preperitoneal fat, and you go to the peritoneum, and you are in. Right, you will see actually a cavity inside, and then that's where you remove your trocar, followed by you put in your whole telescope in, and you will see your peritoneal cavity. You can do this after you use the varus needle to inflate the abdomen, or you can do it straight. But you have to know how to do it properly, because it also can cause injury as well. So comparison of this laparoscopic access. For closed method, there's risk of organ and also organ and vessels injury. But for open method, it's less organ and vessel injury. Visualization for the closed method is actually a blind method, where the open is actually a direct vision. Access time for the closed is actually slightly faster, and the open method, because you need to open layer by layer, so it might be slightly slower. For patient profile, is for the closed method is best to use for patient without any previous operation, where for open method, you can use it for any patient. Gas leak for the closed method is very, very minimal, where for open method is slightly higher. Learning curve for the closed method is lower, because you must know how to do it properly. Whereas in open method, it's slightly easier, because you can do it faster, because we know how to access the abdomen directly. Next is the working port access. This is how you're going to hold the working ports, and when you push in, it should go beneath that. So how is it going to be? When you have to always remember, when you insert the subsequent working port, the trocar and everything must be inserted under direct vision. So let's say you have put in the camera, and then you have made a skin incision and put in the first working part. This is how it's going to look like from inside. And when you're trying to push straight downwards, when it's near to the hollow organ, please turn it to the empty cavity side, so that if, let's say, you push it outwards, it will go and shove towards the empty cavity, and it is safer. All right. So next, we talk about complications of laparoscopic access. So for short term, we can have a hollow visceral injury, like this one show you the gastric perforation or bowel perforation. You can see the whole port is being inserted into a bowel. Next is solid organ injury. You can see the port is being entered and injured to the liver, where it's bleeding. Next, vascular injury. You can also have subcutaneous emphysema if, let's say, the port is not inserted in the proper desired space, followed by gas embolism. Lastly is port site bleeding and hematoma. This usually happens when you injure the inferior epigastric artery. You can see the hematoma is all over the abdomen. Next, long-term complications include port site hernia, port site metastasis for cancer cases, but it is very, very rare. And lastly is port site infection. All right. So just a quick one, complications of pneumoperitoneum or intra-abdominal pressure. Basically, we divide into increased intra-abdominal pressure from the lung, from the heart, okay, and then from the splanchnic and also the kidney, okay, and others as well. And next, we don't forget about it will cause hypercarbia as well. All right. Lastly, prevention of excess complication. So to prevent it, we must assess the risk. So for obese patients, we must be extremely be careful because we know that the access for them might be difficult. However, if let's say patient is malnourished or too thin, the access can be challenging as well. Next, any patient who have previous surgery, we need to anticipate high possibility of having adhesion inside. Next, any patient with peritonitis, especially those patients with end-stage renal failure on CAPD, after they have peritonitis, usually they have a lot of adhesions as well. All right, there's no operation, but then there's a lot of adhesions. So you need to be cautious about that as well. And lastly, any patients with medical history, such as thalassemia, because if let's say they have a splenomegaly, like what I show you in this picture, all right, when you access, when you put in the first pot, you have to be extremely careful because you might injure the spleen. Lastly is the surgeon and the trainee experience. All right, so conclusion, laparoscopic access is the first step in determining the whole course of this laparoscopy surgery, and understanding the basics and complications will enable one to be vigilant during access. And the learning and master both the open and closed method will make a surgeon have more options for laparoscopy access surgery. That's all. Thank you very much.
Thank you so much, Dr. Law. And now we have up next a lecture on energy source and sealing. Allow me to welcome the next speaker. He is a board-certified surgeon with advanced fellowship training in hepatobiliary and pancreatic surgery from the National University Hospital in Singapore. He is an accomplished consultant at Cebu Doctors University Hospital, North General Hospital, and the University of Cebu Medical Center. He also serves as a visiting consultant in several leading hospitals in Cebu. Our next speaker is a dedicated educator and has been recognized early in his career with the prestigious Golden Glove Award. He continues to distinguish himself as both clinician and academic leader in the field of surgery. Join me in welcoming Dr. Andre Ignacio Yu.
Good morning, everyone. Before anything else, I'd like to thank Dr. Lumanto, Dr. Henry Chua, and the other officers and community members of ELSA Outreach Program for inviting me to be one of the speakers for this 119th ELSA OP workshop. Today, I was asked to talk about energy sources and sealing. So disclosures, I have no disclosures. These are the references for my topic outline. First, we'll talk about the electrosurgical unit, which composes about the monopolar and bipolar mechanisms of electrosurgical injury, their prevention, and ultrasonic shear sealing devices, its mechanism, its sealing principle, and different types of sealing devices. So electrosurgery is the most commonly used form of surgical energy in both open and minimally invasive surgery. And due to these advanced electrosurgical devices, it has revolutionized the laparoscopic surgery with increasing undertaking of more complex laparoscopic procedures. As you all know, without these instruments, we cannot do laparoscopic colon surgeries or laparoscopic gastric surgeries. There are many types of energy devices available today, but what is important is learning how to use them safely. So let's talk about the basic, which is the electrosurgical unit. And the the main principle of the electrosurgical unit is that it uh, passes high frequency electric currents through biologic tissues and to achieve specific surgical effects such as cutting, coagulation, and desiccation. In principle, electrosurgery is based on the rapid heating of tissue. So to better understand thermodynamic events during electrosurgery, it helps to know the general effects of heat on biologic tissue. So cytochemical changes do occur below 45 degrees centigrade, but changes are usually reversible, and the cells return to their normal function when temperature returns to normal. However, above 45 degrees centigrade, irreversible changes take place that inhibit normal cell functions and lead to cell death. Between 45 and 60 degrees, the proteins in the cell lose their quaternary oat configuration and solidify into a glutinous substance. This process is termed coagulation. They are usually accompanied by tissue blanching. Further increasing the temperature up to 100 degrees leads to tissue drying. This process is called desiccation. If the temperature is increased beyond 100 degrees centigrade, the solid contents of the tissue reduce to carbon, so a process called carbonization. Therefore, tissue damage depends not only on the temperature, but also on the length of exposure to heat. There are two modes in the surgical electrosurgical unit. You have the monopolar mode and the bipolar mode. So the difference between the two is the method in which the electrical current enters and leaves the tissue. The monopolar electrosurgery tissue is cut and coagulated by completing an electrical circuit that includes a high frequency oscillator, the ECU, the patient plate, the connecting cables, and the electrodes. Electric current from the ESU is conducted through the surgical site with an active cable and electrode. The electrosurgical current is then dispersed through the patient to alert return electrode, returning the energy to the generator to complete the path. So it is very important that any disruption of this path circuit leads to injury, which will be discussed later. So the modalities for monopolar would be pure cut, blended cut, spray or fulguration, and the delivery system is through a handheld instrument as your pencils, or for laparoscopy, it is usually the hook or the spatula. So cutting is achieved primarily with a continuous sinusoidal waveform. Coagulation is achieved primarily with a series of sinusoidal wave fat packets. Fulguration is a high voltage, high frequency waveform. This is used with the electrode held in a short distance from the tissue to create electric arcing and superficial carbonization. So this is usually important when you're trying to stop bleeders in the liver bed. So when you place the mode in spray or fulgurate and increase the power to about 40 to 60, but placing the tip of the hook or spatula just near the liver tissue, not on it, to prevent instruments sticking on the liver tissue, thus creating superficial carbonization, and hopefully will stop the bleeding. So what are the advantages of a monopolar, which is the most commonly used electrosurgical energy? Well, as you all know, it's faster. There's faster tissue dissection, cutting, sealing, and hemostasis. The disadvantage would be, which will be discussed later, there will be a lot of unintentional thermal injury once the circuit is disrupted. So insulation defects, improper dispersive electrode placement, and also sometimes we still see them, if not properly placed, there will be burn over the insulator plate. So how about bipolar? In bipolar surgery, two electrodes, generally the tips of the pair of forceps or scissors, or a bipolar laparoscopic instrument, serve as the equivalent of the active and dispersive leads in the monopolar mode. So bipolar electrosurgery does not require a patient plate. So there will be lesser plate injury. The electrosurgical current in the patient is restricted to a small volume of tissue in the immediate region of the application of the forceps. So this affords greater control over the area to be coagulated, and damage to sensitive tissues in close proximity to the instrument can be avoided. There is less chance of current capacitive or direct arcing to surrounding structures such as the bowel. So what are the advantages of bipolar? Because of its precise localized current, leading to a minimal damage to the surrounding tissues and excellent coagulation of blood vessels, it's designed with active and passive electrodes in close proximity, eliminates the need for a grounding pad, therefore improve patient safety. This localized effect enhances patient safety, especially for patients with cardiac pacemakers, and is suitable for delicate procedures across various surgical fields. Its disadvantage is that it's very tedious and slow to use. Let's talk about the mechanisms of electrosurgical injury. The first would be your lateral thermal spread damage. So this usually occurs at the active electrode site. Injuries can happen because of inadvertent activation of electrode as a result of direct extension of the desired tissue affect beyond the target area. So these are usually occurring when you put the electrosurgical power at the highest mode. So how do you prevent them? So usually when you try to start, use the most effective power setting at the lowest mode. Then when you try to do your cauterization, use short bursts and short possible application during energy-based devices. So another is use appropriate instruments with smaller exposed tips, like your hook or spatula. The use of the Maryland and scissors with cautery must be used only when the laparoscopic surgeon has high proficiency. Insulation failure or current diversion. All active electrodes come with the insulation except at its tip to protect the rest of the instrument and the surgeon, and to make the surface area of the active electrode smaller to ensure desired tissue effect. This insulation can get damaged due to repeated usage, and this can result in diversion of current from the non-insulated area to the adjacent tissues, resulting in injuries such as called as insulation failure. So how do you prevent this? So number one, use quality components. So make sure the instruments that you bought are properly sealed. Adhere to manufacturer guidelines. So if they say that this is going to be used only for 10 times, then use it for 10 times only. Manage operating conditions by maintaining proper voltage and temperature limits. Ensure regular maintenance like cleaning and testing. Implement grounding using insulating pads, and short circuit the current loop before maintenance. Install insulation monitoring devices to detect and isolate faults early, preventing breakdowns and potential hazards. Next, injury with your capacitive coupling. This happens when the circuit is not completed, when an active electrode is activated within the high voltage output, and the user longer instruments with a thin insulation in a narrow metal chokers. So this is a buildup of charge between the conductor and separated by the insulator that can get discharged to adjacent tissues causing injury. So how do you prevent this? Use all metal cannulas. So opt for metal cannulas or systems with a single type of material to avoid creating hybrid insulators. Use the lowest possible power settings. Reduce the power setting in the electrosurgical generator to minimize current. Avoid open air activation. Always ensure that when you activate the electrode, it is in contact with the tissue before activating the current. And regular check for insulation damage. The next one would be direct coupling. This usually happens if an active electrode is activated while another metal instrument is in contact with it, resulting in injury to the tissues that metal instrument touches. So this usually involves inadvertently touching the camera and the other instruments within the abdomen during laparoscopic surgery. So to prevent this is maintain visual control. Always keep the insulated portion of the active electrode and the target tissue in full view before and during activation. Inspect the instruments. Routine inspection of all laparoscopic instruments for any signs of insulation failure. Avoid unintentional activation. So be the only person in the operating room who activates the electrosurgery device. Visual confirmation. Visually confirm the active electrode is not in appropriate contact with any other metal, such as other trocars, other instruments, and proper port placement. So as was discussed earlier by Dr. Gomez, so proper angulation of the other ports will lead to decreasing this type of injury. So let's talk about ultrasonic shears and sealing devices. Okay, so when you talk about ultrasonic devices, we should talk about the mechanism. So the mechanism is usually a high frequency torsional vibration is applied to a slender blade through a transducer. So what is important in ultrasonic shear is heat, compression, and time. So ultrasonic devices uses friction to generate heat, combined with compression and time, the tissue to create the desired tissue effect. When you talk about vessel sealing process, um, the first process would be to clamp the artery or the vein. After that, you need to apply energy. So you push the trigger to initiate the energy device to create or generate heat. The frictional heat on the tissue breaks down the protein bond. Then it denatures the proteins, including those essential for to create hemostatic seals, such as your collagen and elastin. Then there's evaporation of fluid. So increased temperature vaporizes water and other fluid to produce steam. This will then create a sealing effect. The sticky coagulum, along with the additional compression and heat, co-opt the vessel walls. Additional compression and frictional heat and time eventually transects the tissue, so there will be already transection. Now that we discussed the different types of sealing mechanism, we'd like to introduce the type of devices available for sealing devices. The first would be your harmonic scalpel. These are 5 millimeter instruments and have straight or curved tip configurations. The blade temperatures can go up to 105 degrees centigrade, and there is a lateral spread of about 3 millimeters. The 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 advantage of using a harmonic scalpel is that it gives the surgeon more freedom and maneuverability. It doesn't have a cutting option though, but it can only seal to a 5 millimeter uh, vessel. The next would be your ligature. This device is a bipolar electrosurgical instrument that uses the electrical energy and pressure to fuse collagen and elastin in blood vessels. This creates a permanent seal. It is used in sealing vessels up to 7 millimeter. Because of the precise precision of the tips, this minimizes minimal collateral damage and faster healing. Um, the next would be your Thunderbeat, which was a question earlier. So the Thunderbeat is a advanced multifunctional surgical instrument system by Olympus, and it combines two forms of energy: ultrasonic for rapid dissection and advanced bipolar to secure vessel sealing. So this was the answer in the question. It enables the surgeon to simultaneously cut tissue and seal vessels up to 7 millimeter with improved precision. So what is the advantage of using Thunderbeat? Um, it serves as a single multifunctional instrument, so there's no need to exchange a lot of instruments to get two modalities. Its efficiency is the combined system speeds up operations by allowing simultaneous cutting and vessel sealing. And by minimizing thermal spread, the Thunderbeat device helps to protect surrounding tissues and improves patient outcome. The precision would be the fine jaws design allowed to delicate dissection, especially crucial near vital organs and delicate structures. So in summary, advanced electrosurgical devices have transformed laparoscopic surgery, therefore enabling surgeons to perform increasingly complex procedures. There are many types of energy devices available today, but what is important is learning how to use them proficiently and safely. Therefore, a structured energy device safety protocols are therefore integral to a training curricula to standardize proficiency and avoid a range of device-related injuries. Thank you. The question earlier, if what are the other devices, HFA, bipolar, or a sealing device? It depends on how you relate HFA, bipolar. Is it hypomania or bipolar disease or a high frequency bipolar instrument? Thank you.
Thank you so much, Dr. Yu. And now we will proceed to discuss on the anesthetic implications in laparoscopic surgery. We have the highly respected board-certified general surgeon with decades of leadership and clinical experience, serving as a trainer and consultant in numerous leading hospitals in Cebu. He is widely recognized for his surgical expertise and contributions in academic research, in which he continues to advance surgical practice, training, and innovation, particularly in minimally invasive surgery and general surgery. Let us all welcome Dr. Manuel Villamor Jr.
Yeah. You slideshow presenter.
Good morning, everyone. I'd like to thank Professor David Domanto and the ELSA OP, as well as especially Dr. Henry Chua for inviting me and giving me a chance to relate my expertise in anesthesia. Yeah. Okay, so back in about 2011, I traveled from Cebu to Tacloban. That was 2 years prior to Yolanda. and to teach, to be a preceptor for two of the surgeons there in Tacloban. So we started, after an 8-year lag, there was a resurgence of laparoscopy interest. So there were two surgeons and I was the preceptor. So in the start of the very first case that we had, we started early in the morning, and the anesthesiologist, I wasn't too familiar with him. So he gave the usual general endotracheal anesthesia and prep drapes, and then put in the trocars. And when the insufflation was started, the blood pressure crashed. So angrily, the anesthesiologist said, "Stop everything." And noticing that the operative field was very narrow and the pressure of the indicator at the for the insufflator was beyond 15 millimeters mercury, I politely asked the anesthesiologist, "Can you just please give us relaxation?" So muscle relaxation. And true enough, after relaxation, the field was better, the blood pressure increased to normal, and we were able to finish the procedure smoothly. It was safe, okay? And we proceeded to do 4 more cases after that. So this is an example of good communication between surgeon, the laparoscopic surgeon, and the anesthesiologist, okay? So we know all too well that laparoscopic surgery has lesser pain, early return to work, less complications, more cost efficient because it has a faster turnaround time. But before all this would happen, a good understanding of patient hemodynamics and pulmonary function in relation to the effects of pneumoperitoneum is essential to ensure a good and safe outcome during laparoscopic surgery. This is my disclaimer. I'm not an anesthesiologist. Okay. In laparoscopic surgery, 3 factors should be considered: the insufflation of CO2, causing an increase in intra-abdominal pressure with the systemics of CO2 absorption, and the extreme changes in patient positioning. These both are acting on the patient, of whom one should be conscious as well with the patient comorbidities. And this concept, as mentioned by Professor Lo a while ago, will be mentioned over and over again because this is inherent in the procedure. So why CO2? So CO2 is used for insufflation because it is easily absorbed and eliminated, as it is not combustible. Imagine if you use oxygen, the patient will explode, literally. So when CO2 is infused into the abdominal cavity, the pressure increases, and at pressure of 7.5 millimeters, there is compression of the splanchnic circulation, increasing venous return, and a resultant increase in cardiac output. However, when the intra-abdominal pressure increases beyond 15 millimeters mercury, there is pooling of blood in the lower extremity, decrease in venous return, the opposite happens. So there is a decrease in cardiac output. The mechanical effects of the pneumoperitoneum also pushes the diaphragm up, causing a decrease in lung volume and compliance, as well as increase in airway pressure. So consequently, there's a decrease in functional residual capacity and a ventilation perfusion mismatch. So all of us has to be conscious of this, not overinflating and not underinflating, that the operative field is compromised as well. So positioning, so extremes in patient positioning can also adversely affect the cardiovascular and pulmonary dynamics. So the Fowler, which is the reverse Trendelenburg, causes venous pooling and therefore decreases venous return. There's also an increased catecholamines and can also be detrimental for those patients with poor cardiac reserve, wherein you do not want an increased heart rate and increased load on the heart by increasing the peripheral vascular resistance. So there is a risk of, if a patient is compromised, myocardial oxygen demand and probably ischemia and infarction. However, this position favors pulmonary function. The opposite, Trendelenburg, moves contents towards the diaphragm, causing reduced pulmonary risk compliance and increased airway pressure. This position, however, favors venous return. So in all laparoscopic procedure, it is mandatory to apply compression of the lower extremity with elastic bandages to minimize the effect of venous pooling and diminish risk of venous thrombosis and possibly pulmonary embolism. Preoperative evaluation and preparation of patients for laparoscopic surgery follow the same guidelines equivalent to any surgery. So we follow the ASA classification of patients to aid us stratifying the patient's risks based on their physiologic reserves. So ASA 1 to 5. So, you know, ASA 1 are the perfectly normal individual, very good reserves, normal BMI. The ASA 2 are individuals who have coexisting medical issues, but they are corrected and controlled. ASA 3 are those with severe systemic disease with significant limitations or functional limitations. These are COPD, those with known to have alcoholic abuse and cirrhosis, morbid obesity, premature patients for the pediatric cardio, and MI more than 3 months. ASA 4 are those patients with severe systemic disease with constant threat to life. And these are those with MI. Sorry. Okay. These are those with recent MI less than 3 months, sepsis, DIC. So these are very critical patients. ASA 5 are those patients who are very moribund, and they need to undergo the surgery no matter what. They will die if they don't. And ASA 6 are those brain dead who are candidates for organ donation. So generally, laparoscopic surgery has a lower cardiovascular risk compared to open techniques. And understanding the effects of laparoscopy and the pneumoperitoneum on cardiovascular physiology will help us mitigate this risk for a safer and better outcome for our patients. It is essential to adequately assess and prepare the patient. We can identify the risks and therefore anticipate the hemodynamic and ventilatory effects. Then the team can then make a very comprehensive preoperative, intraoperative, postoperative anesthetic plan for the patient. So patient, especially with recent cardiovascular event, may not be able to tolerate increases in preload and afterload, resulting in a decrease in cardiac output. Cardiac ischemia may be precipitated by an increase in heart rate, mean arterial pressure, and increased vascular resistance. So to mitigate this, we must plan for an optimal fluid status pre-op. Appropriate medications like beta blocker and other heart failure meds may be prepared and used when necessary. Closed hemodynamic monitoring is employed and control of body temperature to avoid the effects of hypothermia. Bearing in mind the effects of pneumoperitoneum on hemodynamics, the pressure should be set at less than 15 millimeters mercury with low flow rates. And postoperative pain management should be excellent as well. Okay. So let's go to morbid obesity. So usually has all three comorbidities. Most important of all is the restrictive lung disease with resultant elevated pulmonary resistance and reduced lung compliance. Therefore, if possible, a steep head-down position should be avoided. We should not extubate the patient early because of OSA or obstructive sleep apnea. And if necessary, you use CPAP, BiPAP, so that you can avoid acidosis and hypoxia. Okay, keep the airway patent. Due to the effects of carbon dioxide insufflation, resultant increase in airway pressure and increase of risk of gastric regurgitation, most anesthesiologists prefer general endotracheal anesthesia with balanced inhaled anesthesia and IV anesthetics. The role of TIVA or total intravenous anesthesia has its use with added advantage of reduced postoperative nausea and vomiting and early emergence. TIVA especially has its role if patient has a history of malignant hyperthermia. Talking like an anesthesiologist. There's an emerging trend of using supraglottic airway, especially for laparoscopic surgeries that are quite short. The principle of SGAs is to occlude the esophagus so that there's preferential air towards the glottis or glottic opening and into the trachea. SGA has the advantage of fewer incidents of coughing, laryngospasm, sore throat, and hoarseness. This is an example of the first gen SGA. So it is inserted rather blindly, and there's a device that they use to help in the insertion, and it is fixed over the oropharynx and by inflating the mask. This is a second generation with two balloons. One is inserted into the esophagus, and one is left within the pharynx so that it is a closed system. And then again, there's preferential flow into the airways for ventilation. Now, as mentioned earlier, the most significant factor that alters pulmonary and cardiovascular physiology is the increased intra-abdominal pressure. So the tidal volume is usually maintained at 6 to 8 ml per kilogram, ideal body weight. And to assure and adequate ventilation of the distal alveoli, you employ positive pressure, recruit the distal alveoli, prolong the inspiratory phase, and to correct the respiratory acidosis, you also correct the minute volume, which is the respiratory rate times tidal volume. So if the patient has COPD and respiratory acidosis, you increase the respiratory rate or cycle of the anesthesia machine to blow off the carbon dioxide. For neuromuscular blocking agents, they're very crucial to facilitate intubation, but most importantly, to facilitate the surgical conditions to increase abdominal compliance, and therefore the distance between the bowel and the posterior surface of the peritoneum of the abdominal wall is very far. So that is very important. As a result, the intra-abdominal pressure, excuse me, sorry. As a result, intra-abdominal pressure will not rise excessively, causing disruption of the physiology of the patient, just as the example in early on. The NMBAs can also allow controlled ventilation. Now, reversal of muscle relaxation is by use of neostigmine or Sugamadex. which are the newer neuromuscular reversals. Fluid management. They're very, very stringent in laparoscopic surgery. Hypervolemia can cause edema, impair gut motility, and prolonged ileus, and impaired wound healing. On the other hand, the opposite end, hypovolemia would result in worsening of hypotension with impaired organ perfusion, leading to organ dysfunction and lactic acidosis. It is therefore imperative to employ basic standard of intraoperative monitoring like pulse oximetry, non-invasive BB monitoring, ECGs, temperature, and end-tidal CO2 monitoring. Additional invasive monitors are employed depending on the special needs of the patient and procedures. Patient positioning is crucial to ensure a smooth and safe laparoscopic surgery. Well-padded pressure points are essential to avoid peripheral nerve damage. To avoid accidental falls from the OR table, non-slip pads and body restraints are utilized. Foot and shoulder supports are used to prevent patients from falling on either the Fowler or Trendelenburg position, respectively. And arms are tucked either on both sides or extended less than 90 degrees with the hands on supine position and the thumb on the thumbs up position. Postoperative pain management is multimodal, utilizing a combination of paracetamol or NSAIDs or CO2 inhibitor coupled with local site infiltration with bupivacaine or preemptive analgesia. Preemptive analgesia can also help diminish the need of postoperative analgesics, especially the opioids. So you know opioids can cause ileus as well. Another is the postoperative nausea vomiting is a very unpleasant experience for patients immediately after emergence of anesthesia. The predictors of postoperative nausea vomiting are female patients with history of motion sickness, non-smokers, and post-op opioid use. To control and altogether prevent this, multimodal antiemetics are used with a combination of dexamethasone and 5-hydroxytryptamine receptor antagonists like ondansetron, palonosetron, and granisetron. So in summary, the three factors affecting the patient physiology during laparoscopy are the intra-abdominal pressure caused by CO2 infusion, patient position, and patient factors. A good preoperative assessment is imperative to have a safer, smoother outcome. Therefore, meticulous preparation of assessment can be achieved with good communication between surgeon and anesthesiologists, highlighting the peculiarities of patient comorbidities and operative plan. Patients, especially with limited cardiac and pulmonary reserve, should not be subjected to extremes in position. Airway management is essential to overcome pulmonary limitations and prevent aspiration. Strict IV fluid management is equally essential. Postoperative control of pain and nausea and vomiting is ensured using multimodal therapy, resulting to a pleasant experience for the patient and definitely good and safe patient outcome. Thank you very much.
Thank you so much, Dr. Villamor. And now we conclude this morning's lecture series with suturing and knotting. Our final speaker is a board-certified general surgeon with advanced fellowship training in minimally invasive surgery. He is recognized for his leadership and excellence since his training years. Until present, he continues to contribute to surgical education, research, and service through academic appointments, conference presentations, and community surgical missions, making him a respected figure in Philippine surgery and surgical training. Kindly welcome Dr. Vincent Matthew Roble II.
Slideshow lang. Para. Hindi siya ma-download. Hindi mo dagan ang video. Saka ganun pag single screen ganun display. Thank you, everyone. I would like to thank ELSA for inviting me to speak to you today. I'll be talking about laparoscopic suturing and knot tying. I guess most of our participants are residents. Residente ba nitanan? There are no consultants here? Okay. So I'm sure that you're regularly practicing on your simulators because it's a requirement of PSGS and your training institution to practice regularly, weekly, with a signature of your consultants. I'm sure your simulators are not gathering dust in your institutions, no? So I guess this will be just a review of some of the steps that you will do during laparoscopic suturing and not tying. Sure. So the objectives of this lecture is to understand the principles of laparoscopic suturing, how to handle the instruments and the ergonomics, the different techniques for intracorporeal and extracorporeal knot tying, and some common pitfalls and how to troubleshoot them. So why do we need to learn laparoscopic suturing? No, have you ever heard of a surgeon who does not know how to suture or to do a knot tie? What do you call that surgeon? It's an internist. No, so the same with laparoscopic surgery. Laparoscopic suturing is a critical skill in minimally invasive surgery. You cannot rely all the time on your energy devices or your staples to anastomose or do hemostasis. No, so you still need to learn this skill. If we can learn it in the open surgery, much more in a laparoscopic surgery. So this would enhance your efficiency and also your patient safety. And if you want to elevate uh, your laparoscopic abilities, laparoscopic suturing and knot tying is a very important part of that enhancement. No, I always say that if you want to learn a procedure, you need to have one, the skill, and number two, the technique. No, you cannot have one without the other. No, if you know the technique but you don't have the skill of doing the surgery, then it's useless. Or if you know the skill but you don't know the technique of doing a particular procedure, useless then. So this is just one of those skills that you need to learn. No? So what are the differences when you're doing open versus laparoscopic surgery? So when you're doing open surgery, you're usually in both eyes. You have binocular vision. You have better depth perception. You have better ergonomics. If in an open surgery, you feel that you are at a disadvantaged position, you can always give it to your assistant and you do the suturing because you're in a good position. In laparoscopic surgery, you cannot do that. No, you cannot give it to your assistant. No, so in open surgery, you also have more freedom of movement. In laparoscopic surgery, you are doing surgery on a 3D, three-dimensional field, but looking at a two-dimensional screen.
You have less depth perception. You have no tactile feedback. There is loss of your freedom of movement. You know, you're limited to your fixed port positions. You also have a limited working space. So when you're doing movements in laparoscopic suturing, your movement should be in a small space. No, and the movements are slow, steady, and choreographed. So like a choreography, when you're dancing, your skills in suturing are also being done in steps, no? So what we're going to do today is we're going to break down those steps so that in the end you'll have a good dance in suturing, no? So we're going to use Peyton's four-step approach. Actually, I got this from the ELSA manual, which Dr. Lomanto actually spearheaded. So I would like to thank him for this. So what we're going to do is one, your preceptors here is going to demonstrate for you how to do the suturing itself. Then we're going to deconstruct the steps. We're going to do it step by step. You'll learn it by per step. Then you're going to do it together with your preceptor. And then in the end, you will have a performance. So muna na inyong sayaw. No? So like your gala night na sayaw. It's a stepwise approach. That's why we won third place. So general principles, no? So I guess I'm not going to talk much on ergonomics and setup because the other speakers have already talked about it. So we do have what we call triangulation, the neutral posture. In your dominant hand, usually have the needle driver, but in laparoscopic surgery, it's better if you have bimanual. Your both left and right hands can do the suturing. Your non-dominant usually has the grasper, the assisting tool. So all those things that Dr. Gomez and Dr. Po talked about positioning yourself, you do it also when you're practicing your skills. No, so your triangulation, the straight line principles, you do that. No, so what are the critical steps for suturing? So this is the deconstruction, no? So number one, how to insert the needle into the abdomen. Two, how to load the needle. Three, do the tissue penetration. And four is the knot tying. So we're going to do that step by step. So usually, when we're doing suturing, we don't use the whole suture material itself, no, because it's too long. Again, you have a very limited space. So usually we use like 15 centimeters of suture, no? So roughly about one finger, one hand, no? 15 centimeters. So how do we insert the needle? Now, in this picture, we divide the needle into three segments. You have the segment A, which is 2 centimeters from the tip from the where the suture would insert. Segment C, which is 2/3 from the tip, and segment B, which is 1/3 from the tip. Now, I don't know for the love of God why they made it A, C, B. Maybe the surgeon is dyslexic, but that's how they divided it. So when we're going to insert the needle, we don't hold the needle itself. We hold it at segment A, no, which is 2 centimeters from the insertion of the needle or of the suture to the needle. And then usually we insert it under direct vision through the 10 millimeter port, Now, sometimes we only use one 10 millimeter port, which is the same port we use for the camera. So you cannot insert it under direct vision. So what's the tip for this? No, when you see the target area where you're going to suture, when you have the scope inside, when you remove the scope, you let the trocar be in the same position. Don't move it from another place. So once you remove the scope, when you see the target, you remove the scope, you hold the trocar in place. And then you insert the needle inside, no? While the trocar is at the same position at the scope. And you cannot do it slowly because you're inserting a 5 millimeter instrument into a 10 millimeter trocar. So it's going to desufflate immediately. So diretso na siya sud, no? No? And make sure you don't catch any tissues. Okay? So that's how you insert the needle. Now loading the needle, no. Number one tip is you always visualize the needle tip at all times. Usually hold it 2/3 from the tip using the needle driver, and you orient the needle perpendicular to the tissue. And you avoid excessive manipulation of the suture to prevent fraying. So there are two ways to load the needle, no? So you hold it 2/3. You can either use the dangling pirouette technique or the deposit pick-up technique. So this is just one of the videos. So this is the dangling pirouette technique. So you hold it at section B, and your needle driver, you will hold it at section C. So that's the dangling pirouette technique. Again, so you can position the needle as before you place it on the needle driver. So that's the dangling pirouette technique. So here's another way of doing it. No? In this case, you're holding it at section C, the assistant grasper, and you hold directly to section A, then section B. Now I'm confused. So just watch the video. So you hold the suture at A, and you hold it at C. Dapat ABC lang na. Anyway, and you position the needle as perpendicular. So before you suture, you can do a practice stroke to make sure that you are already perpendicular. Now this last video is the deposit pickup technique. So you just put the needle and you just pick it up directly at C. No? So this is very useful in cases when you only have one instrument or one hand available. So let's say your left hand is controlling a bleeder. You need to insert a needle and you need to pick it up the needle only with one hand. So you can put the needle on top of a flat surface. Usually we put it on liver or the body of the stomach. No, don't put it on the bowel because it might slip off and go inside the mesentery. The body of the stomach is quite thick, so there's no danger of perforating it. So you can put it there and do the deposit pick-up technique. But you need to exert a little bit of pressure to make the needle align on itself. So tissue penetration. So you pronate your wrist to enter the tissue at about 70 to 90-degree angles. This is to prevent tearing of the tissue. If you don't pronate your wrist, you would tear the tissue once you start penetrating the tissue. No? And you follow the curve of the needle. That's very important. No? You follow the curve of the needle. And you can use counter traction, the opposite instrument. So again, you hold it at 2/3 from the tip. You pronate your wrist and enter the tissue at 70 to 90 degrees angle. Then you can use your other instrument, your assisting instrument, to stabilize the tissue. Meet the needle on the opposite side. And you can pull the needle following the curvature of the needle to prevent tearing of the tissue. So that's tissue penetration. So not tying now. We're going to knot tying already. No? So you have two types of knots. You have the intracorporeal and the extracorporeal knot. When you say intracorporeal, you're doing the knots inside the abdominal cavity. Extracorporeal, the knots are outside. No? So the advantage of doing it intracorporeally is that you have a limited suture that is drawn out of your abdomen. So there's less trauma involved to the tissues itself. And you can use finer sutures when you're doing the knot tying. For the extracorporeal, you're actually using familiar knotting techniques that you use in open surgery. So it can be easier for, especially for beginners. It can also be used for free ending structures such as appendixes, transected ducts or vessels. You can actually use it even for the gallbladder if you dissect the whole gallbladder off the bed before you suture the duct. No? But it's not for suturing delicate structures because it would tear off, especially when you tighten the knots already. No? So intercorporeal, we're using the Medtronic suturing system. There's actually what they call a knot guide. So this knot guide would help you practice your movement in a very economic manner, or there's what we call economy of movement. Very small movements only when you're doing the knot tying. So in this case, your assistant grasper is on the 7 o'clock position, while your main suturing is following the pattern on the knot guide. So how does it look like when you have the suture already? So again, the assistant on the left, and you follow the knot guide going up and follow the second row. So it teaches you to make your movements smaller. So when you're doing laparoscopic knot tying, your movements has to be in a very small space. You do not do very large movements, no? So you can practice that on the back later on. So we have two techniques of intracorporeal suturing. They have the Zabo technique and the Rosser technique. The Zabo technique, they call it the drop needle method. You see again, you enter, you hold it at the C position, A position. You penetrate the tissue like what we said before. Follow the curvature of the needle. Brace the tissue to prevent tearing. And then you try to make a small tail. That's also an important part of doing the suturing, small tail. And then they do what we call a C loop. It's a letter C. Later on, I'll teach you how to do it. Then you can do a hump. Do 2 loops and pull your short tail with one going to the 2 o'clock and one going to the 7 o'clock position. Then you transfer to the opposite hand. Again, make your C loop. And going over the knot, again, make your second throw. Then transfer to the opposite hand. Again, make the C loop. So sometimes they always tell you to make the C loop, but they don't tell you how to do it. So sometimes if you get lost, all you have to do is to make sure that this suture is parallel to the instrument that's making the loop. No? So you just pull it towards you, no, to make the C loop. No? So the Zabo technique is useful for sutures that are still quite long, no? When you're suturing the first 2 or 3 knots, no? The Rosser technique, you don't transfer it to the opposite hand, but you do like an open suturing, no? So again, the same. You hold it at A, inside. Then you put the driver on C. Make sure that it is perpendicular and 2/3. Penetrate the tissue at 70 to 90-degree angle. Follow the curvature of the needle. Assist it with your needle driver and pull it out, still following the curvature. make a small tail. And when you're doing the roster technique, this is the important part. The concave area should be going down so that you won't have difficulty doing your loop. No? The U shape should be in a U. No? So again, this suture should be parallel with the needle driver that's doing the loop. So again, you go back. You don't transfer already. You don't transfer the opposite hand. You go under the suture to do your second throw. So again, the important part is the U shape of the needle. If it is in the opposite side, you will have difficulty doing the loop. So what about extracorporeal knot tying? No. So this is when the suture is passed and tied externally. No. And then the knot is pushed into the cavity using a knot pusher. Sorry. So useful in confined spaces and long sutures. No. Again, there's a risk of tissue strangulation because you're gonna push it towards the area where you're going to suture or close. No? So there's a lot of knots that can be taught, but I guess the Roder's knot is one of the most popular knots. So we'll just teach you the Roder's knot. No? So the Roder's knot, pardon the dirty shoelace. I just got it from my shoe. So you do one loop, a simple loop, and then the shorter loop would go under the two sutures 3 times. 1, 3 times. And then on the last suture, last loop will be a half hitch. So going under the one suture and like that. So there's a lot of videos like this in YouTube. So you don't need to record it because nara sa YouTube. And then you push it towards the area where you want to suture. And there's another way of doing it. Actually learned this in Vietnam from a nurse. I don't know what it's called. I'll just call it the snowy knot after Dr. Obensa's friend in Vietnam. So you do a loop, then you put it inside 4 times. So this is useful for blind ending structures. Usually in Vietnam, the nurses do this and they just give it to the surgeon. Akin wala ni sa YouTube. So that's a ready-made loop already, no? Taught by the Vietnamese. I don't know what it's called. So tips and tricks. So again, you need to align your needle path with your visual axis. The needle should be visualized at all times when you're doing the surgery. You form the initial C and a short tail. So when you're confused, sometimes when you're doing the actual surgery itself, the trocars may not be in the same position as what you're doing in the simulation. So if you're confused on how to do the C, just make sure that the suture is parallel to the instrument that is making the loop. So you just pull it towards you and it becomes parallel. And then that's the time you do the loop. That's how Dr. Roselio taught me. No? So you use your wrist rotation for a controlled motion. So you always pronate your wrist to make sure that you enter the tissue at that 70 to 90-degree angle. You execute your knots near your tissue surfaces. So you don't make your knots away from the area where you're going to secure. Again, economy of motion. So you need to practice yourself that you're going to do very slow, steady movements, not jerky movements. Again, this is not a contest when you're doing actual surgery. Siguro as a contest, you can do that. But when you're doing actual surgery, slow is smooth, smooth is fast. No? So you practice hand dominant switching. So your left and right hand should be able to do the suturing itself, ambidexterity. And you move the two units as two instruments as a unit. No? So when you're doing suturing, both instruments should be moving together. So common errors, you have incorrect needle orientation. Sometimes the needles are not in a 90-degree or not in a perpendicular position, causing tissue tearing. If you have two long tails or a very long tail, once you do your knotting, the long tail will get caught up on your next knot. No, so you try to practice using short tail. Just sometimes when you're a beginner, too short a tail, the next time you do a loop, it's gonna come out. So you can practice first with long, then eventually you can do the short tail once you get the hang of it. No. So if you do have loose knots, you would lead to a bleeding or an anastomotic leak. Over tightening, especially with extracorporeal knot techniques, can lead to ischemia. If you have poor ergonomics, you're going to have fatigue and tremors. So the take-home message for this is that one, you need to practice. So it needs repetition and patience. Again, it's not a contest. Well, later on there's going to be a contest, but when you're doing it in the real patient, it doesn't have to be that fast. It just has to be smooth. No, you focus on your ergonomics, your precision, and your knot security. And of course, simulation training is very essential. That's why we're doing this lectures. So thank you. Thank you.
Thank you so much, Dr. Roble the second. And we'd also like to thank all our speakers and esteemed lecturers this morning for your valuable knowledge and insights shared for the lectures. No? At this point, we would like to open the floor to questions. We encourage our participants to direct their queries to the specific lecturer you wish to address, so we may have a more engaging and fruitful discussion. We have 5 to 6 occupied tables, and anyone who would like to ask any questions, feel free to raise your hand.
So I think before we ask from the on-site participants while they're thinking of questions. So there's one question from an online participant. And then the online participant is asking, may I know how you maintain low CVP and which measures you usually practice in pre-op, intra-op to get low CVP during lap surgery?
I think this question is for Dr. Villamor, the lecturer on anesthesia. So again, the question is, may I know how you maintain low CVP and which measures you usually practice in pre-op, intra-op to get low CVP during lap surgery?
Okay, so let's define what is normal CVP first. So that is between 3 to 12. That's normal. So as mentioned earlier, we have to be very strict with fluid management. As mentioned as per experience, if we do not preload a patient with fluids and then we infuse we suddenly infuse air, pneumoperitoneum rapidly, definitely that patient's going to crash. That being said, we have to balance between good hydration and not overhydration. So how do you maintain low CVP? We do this for invasive procedures. I mean, invasive monitoring procedures. You really have to put a central line, put it near the right atrium, and so on and so forth. Again, um, it's not so much how you maintain low CVP, but rather how to give an optimal fluid management for a particular case. So it's more of putting, if the patient is high risk. So I think you're asking this question because this patient is a cardiac patient and you really don't want to overload, okay? If the patient is high risk, put your pressures of the abdomen maybe 7, 8 to 10 and never beyond that. Ask the anesthesiologist if he can give adequate relaxation without compromising cardiac function. And then just give enough to maintain a normal blood pressure and not to precipitate tachycardia so that there will be increase in heart oxygen demand. So it's not so much in the numbers, but so much more on the optimal fluid management to keep the patient in relative homeostasis. Thank you.
Thank you so much for our online question and to Dr. Villamor for answering the question. Again, the floor is still open for any questions. All right.
So we have usherettes on the side. If you need the microphone, you can just raise your hand if you want to ask a question.
All right, we will now proceed with our program. With the interest in time and given that no questions have been raised so far, we will now proceed to the next segment of our program. But before we go to lunch, we would like to announce a slight adjustment in the schedule. Fortunately, we are running ahead of time, and we would now proceed with the sharing on Olympus Continuum. Following that, we will have a post-lecture quiz before lunch, and we hope this change will give us a smoother flow for the activities this afternoon. This in minimally